Me too.
All right, we are live and so happy to be back again for our Friday Facebook segment, Caring Conversations. And our goal in these conversations is to bring topics that we know are so relevant for our clients, our caregivers, their families, and our healthcare partners. My name is Julie Kalana, and I am the founder and president of Open Arms Solutions. And for those of you that don't know, Open Arms is a home care company. We provide a team of professional caregivers and care coordinators that help seniors and their families navigate the challenges of aging, and we proudly support their dignity and independence in their own homes. With me today is the very famous and lovely Katie Monahan Brooks. Katie was recently married, and I had the privilege of seeing the video of that marriage, and it was an incredibly, in this environment today in COVID, when you see something so warm and lovely and loving, it was great. It was a treat. So I loved watching that, Katie. Congratulations again on your marriage, and I'm so glad you're here. Katie's in charge of business development for Transitions Hospice. And we have a bonus today, and I'm so pleased that Dr. Kapur can join us with Katie. Dr. Kapur is a board certified in palliative medicine and the medical director for Transitions Hospice. And thrilled that you're joining Katie and I in this conversation, Doctor.
Thank you for having me.
Absolutely. So our topic today is such an important one. It is understanding the difference between hospice and palliative care. It's very confusing to families, and truly it's very confusing in the healthcare field overall. There's a lot of education that continues to go on, and that's really important to educate healthcare professionals as well. So for those of you that are joining us this morning, if you have a question, and I suspect there will be questions today, please put the question in the chat box, and I will be checking it, as well as our trustee, Sarah Mattis, who's behind the scenes helping us run this program. We'll be checking it, and we'll do our best we can to answer those questions. So let's start out with this, if you will. Katie, Dr. Kapur, can you just tell us a little bit about yourselves and ultimately how you ended up in healthcare and how you ultimately arrived in hospice and palliative care at Transitions? So Katie, would you start?
Of course. I actually have a degree in music therapy, and I started my career working with a number of geriatric patients. I worked in geriatric psych, I worked in nursing homes, I did recreational music. I worked with a wonderful group called the Harmony Clubs up in Wisconsin to go ahead and work with individuals in adult daycare. And I absolutely fell in love with the senior population. And over the next 15 years, my career morphed, and I got into business development and was given an opportunity in January of 2019 to join the Transitions team. I had actually worked with them previously in a number of my other roles and really respected how they ran their company and the type of care that they provided. It's a family-owned business. It's been around since 2007, and Jim Palazzo, our owner, really made it a key point for everybody to understand that we're doing this because we want to provide care at a critical time, and we want to do the right thing by our patients. And that was something that really stuck to me. And I wanted to be with a company that not only understands its mission, but also lives its mission.
Absolutely.
So that's how I found my way to Transitions. Dr. Kapur's story is a little different.
Tell us, Dr. Kapur, how did you arrive where you are right now at Transitions?
Yes, so my background is internal medicine, geriatrics, palliative care, and hospice. And, I really, as I was a child, was around nursing homes a lot because my mother was a CNA in the United States, nurse in India. And with that being said, and then having a father who was a chemist, R&D manager at a chemical company, I had a lot of influence. being around elderly patients. So as I progressed in my career, internal medicine was the right way to go. I always found myself being navigated toward those cases where there was suffering. And so after you do that for a while, you follow your enthusiasm in life, right? And so my enthusiasm was going toward this population and completing that circle to take care of them from being an adult until the end of their life. So that's my mission. I had some experience in skilled nursing facilities, being a medical director there, doing palliative care consultation and cardiology suites earlier in my career, and running a small hospice team as a team physician at a different company. And then I became the medical director of a different company for 4 years in hospice and palliative care. And then I was asked to be the chief medical officer here at Transitions. And I just felt like I would be able to, at a larger level, really impart the passion and expertise that I've developed over the years to a broader station.
That's great. That's wonderful. I really appreciate it. I really appreciate your comment. We tend to follow our passion, and
Right.
That's really well put.
Thank you.
So tell us, I think one of the more important things for discussion is, what's the difference between hospice care and palliative care? There is so much confusion about that. Katie, you want to start with that one?
I'm amazed at how many people, whether you're talking about hospice or talking about palliative care, their ears shut down because there's such a misconception that palliative care and hospice care are the same thing, and all we're doing is talking about death. And it could not be more different. We'll start with the scary one. We'll start with hospice. Hospice truly is care for individuals at the end of life. And end of life simply means that they have a terminal diagnosis. It means that without aggressive treatment, the likelihood is that their life expectancy is 6 months or less. Now, I know many individuals, and none of them have a crystal ball, and no one can pinpoint exactly when someone is going to leave this earth. We've had hospice patients who have been on with services for much longer than 6 months. We have individuals who graduate off of hospice services, meaning that they no longer qualify, that they've actually gotten better. But the amazing thing is that we are providing compassionate care to keep individuals comfortable wherever they call home under a Medicare benefit under the hospice ideology. Whereas palliative care is for those individuals who maybe do have a terminal diagnosis, maybe not, but they have a chronic condition that really needs assistance and long-term management. This could be individuals who have cancer and are going through chemotherapy or radiation or immunotherapies, but are dealing with a lot of side effects. They're dealing with insomnia, they're dealing with weight loss, they're dealing with nausea, maybe they're dealing with anxiety or depression. And so palliative care's goal is to come in and manage all of those other symptoms. And what can we do to help make their quality of life better while they are continuing to receive these life-saving treatments or life-prolonging treatments? And we also see areas where palliative care can be super beneficial in some more clinical cases. Dr. Kapur, would you like to maybe talk about how we use palliative care with dementia patients?
Sure. So there's lots of different types of dementia, Alzheimer's being one of the most top. And then we have Lewy body dementia, which is hallmarked by hallucinations and falls. Sometimes we have mixed dementia, where it could be a combination of a vascular plus an Alzheimer's. And then we go down the list, and there could be frontotemporal dementia, where there's executive function issues. Plus any neurologic illness like Parkinson's would have a dementia 10 years after the diagnosis. So with that being said, there's a lot of needs that come up with advocacy, with symptoms, and also with coordination of care in the community. So I can give you an example. We received a consult from downtown Chicago, which was transferred over to Northwestern, and who trusted us to see the patient in the home setting. And so we ended up seeing the patient in the home setting, coordinated with all the physicians that were involved to make sure that they knew the symptoms might have been changing. And we needed to address hallucinations that were worsening, and also some sleep issues and agitation and falls. So palliative care was the initial way that we get involved with the patient, develop rapport. We were able at our company to get a palliative care social worker to be involved also in coordination with the Northwestern team, so that there was also collaboration, coordination with their expertise and their palliative care side, which was wonderful. So right now, we are on a basis where the family feels so comfortable with calling us whenever there's a symptom that comes up. We see this patient weekly to make sure that everything is taken care of. And remember that palliative care is covered by Medicare Part B, so it can go in conjunction with a home health company if it's appropriate, and also in a post-acute setting, which is also covered usually by Medicare Part A. So palliative care, which is Part B, goes along with that. So in this particular case, we really made a difference for this family. Education was really needed in this case. Understanding that we need to talk about the advanced directives. They had some time to look over the POLST form. I was able to give that to them. Also, we were able to educate about tube feeding versus not tubing in context of where there's illness, and giving education about what their options were. And these are discussions that come up as the disease progresses. So we were able to do that very well. We have a nurse practitioner that lives very close to the patient, who's been seeing the patient, coordinating weekly in collaboration with me and the entire team, where we have an email thread going.
That's
so great. It's wonderful advocacy, symptom management, spiritual support if needed, social work support. And what makes us really different is that typically you don't have 24-hour access to a provider in the palliative care arena. That's more, people usually think that that's okay, hospice, it's going to be 24-hour care. But the way we have things set up, we are able to pull from our team if they had a problem in the middle of the night and get them in touch with our nurse practitioner so that
That's terrific. That is terrific, Doctor.
And that's
what you mentioned. Oh, go ahead.
That's very different than other places. Yes.
Okay, thank you. One of the things you mentioned, you used the term the pulse, and I'm suspecting that many people might not know what the pulse is. I do, but it's a really important document, and it's so important that families know about it and address it. So can you just at a kind of a high level share what the pulse document is?
Sure. So we do this typically with all patients that enter a hospital, but especially in a initial palliative care consultation, we're going to go through what their options are should there be an emergency or the pulse would stop. So how I go through this with patients, if and you were to find your family member or you were to be found gone, would you want resuscitative efforts in light of your prognosis and what's happening? Because there comes a point where we can do more harm than good by doing that. Not only, with the family that has to watch the aggressive maneuver, but the chances of coming out of such a resuscitative effort when your prognosis is 6 months or less is 1% or less. And so it is a protective order in certain situations to have a do not resuscitate. So there's that option, but then there's also the option to select a selective DNR. You can be a complete comfort care only, do not resuscitate me, allow for a natural death, or you can have a selective DNR and select that on there, which means we're going to try some things. We might try a BiPAP to kind of help you breathe, but not put the tube down and put you on a ventilator. There's also the option of trying IV fluids, trying IV antibiotics, but not too aggressive where we're going to put you on a ventilator. Should somebody decide that they want to be resuscitated and have the full aggressive maneuver done, then I ask them, would you want prolonged ventilation? How long would you want to be on the ventilator? And most people will say, until there's no meaningful chance of survival, which is usually 10 days in an ICU setting where complication rates go up.
Yeah, that's great. And I will say that there's a question that was just asked. So let me make sure a viewer asked the question, does private insurance pay for palliative care?
Yes, in some cases it does. Everyone has to go ahead and take a look at their own insurance policy and talk with their insurance provider to determine if palliative care is covered. We are seeing now that most private insurance companies, along with Medicare, Medicaid, and veterans benefits, do offer some, if not complete, coverage for palliative care.
Got it. Thank you. And I think what I wanted to add to what Dr. Kapur said is that we see our team is with families that we're caring for someone who we're helping them at home. We're helping them stay home to preserve their independence. And I know this from my own personal experience and experience with the hundreds and hundreds of families we've helped throughout the years, that often families don't have these conversations until there's an emergency.
Exactly.
I know that was the situation with my family.
And same with mine.
Mm-hmm.
And I was I was really motivated, and a lot of people have heard me talk about this, to have conversations, and I have conversations, probably not enough, but to educate people about a couple things. The reality is, at some point, our loved ones are going to decline and they're going to pass away. And would we rather know what their wishes are when they can tell us what their wishes are? Or would you rather be in a panic like I was, which my mom got to the point where she couldn't really communicate to us. And my siblings and I didn't truly understand her wishes. And that is devastating. Mm-hmm. It's just a devastating feeling. So yeah. I think that this whole topic is so near and dear to my heart. I shared with you, Dr. Kapur, my personal experience I had with the hospice team that cared for my mom, which was extraordinary. This is now almost 14 years ago. But they helped, I guess I will also say, and I just want to add one more thing. And this is something we see to families. So often they say to us, I wish we would have called hospice, or I wish we would have called, for palliative care so much earlier that we did. I mean, that's the most typical conversation we hear after someone's passed away.
Yeah, we hear the same thing. I actually, we have that leads us into the viewer question we have. What are the first steps to take when thinking about hospice care for a loved one?
Yeah, it's a great question.
And realistically, you need to look at what is your goal? What are the goals for the quality of life versus quantity of life for your loved one, especially if your loved one is part of the conversation. For those who are blessed enough to have a loved one who can share what their wishes are, ask them, do they want to first and foremost live out the rest of their life at home? For most of our patients at Transitions, they want to live out the rest of their life in their home, whether it's in a private home or in an apartment or an assisted living. That's their home, and that's where they want to be. Most people don't want to go someplace to die. They would like to do that at home. But there are other situations where some individuals aren't comfortable with being at home, or they don't have the resources to keep them at home. I know that, in my beginning career of hospice, I had a conversation with a young mother who was only a few years older than myself, who had terminal cancer, and she had 2 young children at home. And she did not want her children witnessing her death in the home and being aware of that. So instead, we went ahead and we found a place that she could go in a hospice house situation that would give her that option. But we've been a community-based hospice since our founding, and our goal is to make sure that people live out the rest of their life wherever they want to call home. So that would definitely be your first step. And then at that point, it's time to research hospices. Hospice is not one size fits all, and you want to find a hospice that you're comfortable with, that you feel is going to go ahead and meet your needs. Some of the needs that are going to certainly be met, you need to make sure that they have qualified nurses that are going to be able to come out and see you and spend time with the patient as frequently as may be needed. Routine care usually means that someone is only being seen about twice a week for a nursing visit, with about 2 times a week for a CNA or an aide visit to assist with some personal care and bathing needs. There's also social work components to look into. There's chaplaincy and spiritual care to look into. Volunteer needs. If you need someone to come and spend some time with your loved one, to give you a little bit of a break. And again, remember, there's nothing wrong with saying that you need a break when you're taking care of a loved one. Self-care is just as important as caring for our loved ones. And also understanding what extra services might be available. Is there a massage therapist? Is there a music therapist? Is there animal assisted therapy as an option? All things that we offer at Transitions to go ahead and help people with some of the other needs, that are outside of the medical realm, but still so much in the human realm.
Oh, absolutely. And you mentioned a couple of things that I think I just wanted to reinforce that there are often misconceptions in that often families need support, additional support in addition to hospice. I mean, the nurses are wonderful. All the social work is wonderful. The music therapy, I told you about the experience with my mom, Katie. I'll never forget it. It was amazing. But what happens when someone starts, at least our experience, when someone starts to decline, there needs to be someone available to be there for that person, to make sure they're comfortable, to make sure they're attended to. And so either there's someone in the family that wants to take that responsibility, and sometimes that's the case. Sometimes there's someone that really feels they want to do that, and it's important to them that they provide that role. Sometimes people, and we talk to people, don't realize, oh my gosh, I didn't realize, that there's someone's going to need to do that at some point, in addition to the nurses, in addition to all the support. And so that's an important, I think, conversation for families to have. Often home care is brought in when families can afford to be that person, where the spouse wants to be the spouse. They don't want to be the caregiver. And for whatever reason. So it's just important for families to understand what hospice provides and sometimes what additional help is needed. So that's a question I think it's important for them to ask.
It's interesting that you mentioned that. We understand that there are financial constraints. We're very lucky that hospice is 100% covered under the Medicare benefit. It's also typically covered 100% under a number of different private insurances, under Medicaid, and of course under veterans benefits. But we also have a program that's really unique to us. It's called our Vigil Sitter Service program. And that means when individuals are actively transitioning, or the family is really just needing a break, we actually have staff members that can come in and just spend time with the patient. So that allows for, a wife or a child or a husband to get that 8 hours of sleep that they so desperately need uninterrupted, knowing that their loved one is being cared for by a professional who will be there to assist them in their needs.
That's great.
As well as to make sure that they're not alone.
Absolutely. Thank you for that, Katie. So one important thing is, can you share with us a little bit about something that's on everybody's mind right now?
You mean COVID-19?
That was a good guess, Katie.
It was either going to be that or election results, but I'd rather talk about how we handle everything with COVID-19.
I promise you we're going to ask you about COVID-19.
COVID brought a whole host of new challenges for everyone, and they are wild and rampant in the healthcare community, as everyone working in the healthcare community knows. But specifically under the hospice world, we are caring for patients with COVID-19. And surprisingly enough, a lot of our patients with COVID-19 have survived COVID-19. And they are continuing under our services. So the heightened need for PPE, personal protective equipment, and utilizing that correctly has been paramount under hospice, not only to keep our patients and their families safe, but also to protect our staff members. Transitions worked diligently at the front end of this to make sure that we were never going to run out of PPE for all of our staff. So that included masks, that included gloves, face shields, gowns, you name it, goggles. I think we have more hand sanitizer than one could ever possibly use in a year, and yet, well, we're using it, um, and certainly making sure that we're able to do that. The other thing that we've been able to do, we were now given the opportunity to be able to see patients virtually. Telehealth visits were authorized under Medicare for us to be able to see patients via Zoom. And so obviously that doesn't replace an in-person visit, but if there is a question, if there is, just maybe a small symptom that can be managed without a visit in person, we're able to go ahead and do that Zoom check-in, which has been really, really wonderful, especially for patients who are in nursing homes, where of course we are desperate to go ahead and keep the virus out of these places, because as we saw what happened in the beginning of the year, they can just run rampant through a skilled facility very quickly, and they can be very devastating.
Yeah.
The other thing that we did is we developed a COVID-19 task force internally that is in charge of staying on top of CDC guidelines and recommendations, and disseminating that information and education to our staff so that as things change, we can change with them as well. This was the task force that was able to get our telehealth up and running in 2 weeks. This is usually a process that takes about 2 months. So we have been very, very blessed to have individuals on our staff who are ample and able to go ahead and get us on board with some of these new techniques and new technologies. The other big end is patient and family training, and really helping them understand about, safety and cleaning and everything that they go ahead and need to do on that end.
All right, that's great. Thank you for that, Katie. And it's those of us in healthcare, it's number one on our mind. How do we keep our caregivers, nurses, and everyone who goes into the home safe? How do we keep our clients safe? Many of us, where we go into senior living communities as well, they're relying on us to do things the right way. So it's a big responsibility.
I'd like to make one comment on COVID-19, and that, we are going through somewhat of a second surge right now in Illinois, at least. And, the importance of reaching out to our elderly population and having them be, watched over. There's a lot of social isolation right now. Therapists and psychiatrists are being sought out, very highly at this time because of the anxiety surrounding COVID-19 and keeping oneself safe, but yet connected. So, that's why I think it begs the question, how do we accomplish that? And that can be also accomplished through your agency, as well as coordination and clustering visits so that there is that outreach.
Yeah, that's such an important point. Thank you for making it, Dr. Kapur. It's, so many of the people that we take care of are living alone, and we might be the only people they see that day.
Right. It's true.
Or that week.
Right. So just paying attention to that and having family and friends really being aware of it and really help and reach out and check in is so important. We are almost out of time. I told you. Go fast.
I think that though, as you're mentioning the things in home, I think that's the other thing that people don't necessarily realize about both palliative care and hospice. All of these things take place in the home. So patients aren't going somewhere. They're not going to hospice. They're not going to palliative care. So they're not going to a doctor's office. They're not going to a hospital. And they are reducing their risk of exposure right now. So for individuals that are really concerned, palliative care might be a really great option for you if you do have chronic conditions that need to be managed and you're looking to avoid going out to a doctor's office or the hospital on a regular basis.
Very, very important
and
point.
Really the triggers for palliative care would be increased symptoms, increased need for surveillance, given more falls, increased hospitalizations, using more healthcare resources, more labs being drawn, and of course, need for education, really. That's the idea of getting palliative care involved early. If you get palliative care involved earlier in your disease process, then we can really help you not only live better, but longer, because sometimes less is more in geriatrics.
Oh, what a great point. And what a great way to start to conclude the time together, because there is always that stigma. If I call, is this somehow going to hasten my demise or my loved one's demise? Because it's something we don't like to think about, we don't like to talk about. But the absolute reverse can be true, especially with palliative care. People can live longer, they can live with more comfort, family members can feel supported. It can be a very, very positive experience for all. Well, we are at the end of our time together.
I know, it's amazing.
Very, because you guys were both engaging guests with really important information. So thank you so much for taking the time. It was a pleasure to meet you. Dr. and Katie, great to see you as always. Thanks for the wonderful work you do for the community.
Thank you.
And thank you as well.
All right.
For all you do.
Thank you. I appreciate that. Take good care.
You too.
Bye.
Bye now.